endoscopic surgical atrial fibrillation treatment in patients with persistent atrial fibrillation.
Dear Chairman, dear colleagues, we all know very well, meanwhile, or it doesn't work in the moment. Yes, we all know meanwhile very well that we can find a lot of origins of atrial fibrillation in the posterior part of the left atrium and where the connection area of the pulmonary veins is. And so it seems to be a good idea to create a box around this area to isolate it and to restore sinus rhythm. We use this U-shaped tool with an option for suction from outside to create this box around the pulmonary veins, like you see it on the right side. And so what I want to say about the technical background, we have seen it a little bit before. The U-shape is not only for stabilizing this tool at the outside, it's also allowing to suck a fold of the tissue of the left atrial wall inside of the U, and then we are able to apply a bipolar and unipolar energy as far as we want. So to prepare the way around the pulmonary veins, we use these natural rays, the transversal sinus, the oblique sinus, and of course then we use some introducers to bring in the tool. This is what we have seen also before. And this is the way we want to do it since 2012. You see it's a complete endoscopic procedure with 2 working ports in the scope, and this is the typical example for a cosmesis result. So what we did in these 32 patients is to create a unilateral endoscopic ablation procedure like a box lesion. All of them were in a persistent or long-standing persistent atrial fibrillation status before. That means it was longer than 1 year. And we have had a follow-up of, meanwhile, 24 months, and I would like to show here the short results from 80 months. There was an option to send the patient back to the cath lab procedure when it was necessary. That means when we detected atrial fibrillation again at 3 months. This is the curve of the freedom from AF, and we have heard the discussions before. Of course, we used an event recorder in most patients. That means about 70%. And what we have seen is after 3 months that we have to send back 2 patients to the cath lab, and then we detected a success rate of 100% in the follow-up time. The consequence of all of this is that we are able to reduce the intake of warfarin and antiarrhythmic drugs. You see it here. And we have also seen that the LA diameter was decreasing from 48 to 44. One of the main results, what we have seen, is the improvement of the quality of life in these patients. You see here very well, we use the SF36 form, very well the physical problems, the emotional problems before, and of course the general health feeling was very poor, and it was completely increased or improved after the procedure in the follow-up time. So what I can conclude is that we are able to create a box around the pulmonary veins when we use this tool, and this is the basic for a hybrid approach, what we can use after 3 months, and it's very helpful to improve the quality of life in these patients. Thank you very much.
Thank you, Ralph. Any questions?
Yeah, so for the sake of time, maybe we will leave the questions also to you for the next part of the session. And I would like to thank you very much. I know, Jen, if you have any question. I just wonder if I have just short question. You have experience with this Carter evaluation afterwards. What is your opinion on the roof line using this on the roof line epicardial?
We have a lot of experience, electrophysiological findings after the ablation, but we have no problem with roof line. The main reason of atypical left atrial flutter is left isthmus, not complete line to mitral, and that's why nowadays we use only cryo to creation mitral line and creation through tricuspid line if we do biatrial maze procedure.
All right, thank you. And Ralph, I just wonder if I may, if you have a really fatty heart, so what is your technical advice to use this device?
Yeah, one of the main points to use this suction function of this device is to be sure that there's not fatty tissue what you are sucking in, that is really the surface of the left atrium. And so, of course, especially in the waterstone groove, you have to dissect the fatty tissue until the surface of the left atrium, and it's the same to the transversal sinus. It sounds to be difficult, but it isn't. When you use your scope and when you go inside of the sinus, you can see very well what you have to do, and it's really nice to do. Yeah.
All right. Just Timur, short.
Yeah, one quick question, because it points at the same direction. We had in our series using a different device, body mass index and fatty tissue as predictor of failure. And my question would be, do you consider to deviate from that approach in terms of doing something else, a MACE 4 procedure, minimal invasive or something? How do you select the patients that you would say this approach might not be the best for a certain patient? Because I stopped doing it on very fatty, epicardial fatty patient.
This is one of the main problems we have. The selection of these patients is more or less not our selection, it's the selection of the EP. That means the EP is sending the patient because of the fact that there's a long-standing persistent atrial fibrillation. They don't want to do this. It's more or less the same in both centers. And that what we agree before we start is always we can do our box lesion and we can do our procedure in an endoscopic way. And the second step, when it's necessary, is the step for the EP. And so, of course, and you are completely right, when you have a lot of fatty tissue, you have to dissect it, and sometimes maybe you are not able to go to the other side with this technology, and then you could have the situation that you're not able to show the block at the end of the procedure. And so in these cases, we send the patient back to the cath lab. Yeah.
Okay, thank you very much. Very good presentations. We have to move on to the next one from Beijing.